was the safest molecule when we wanted to treat diabetes. I think that is what we've got at least in last 1 decade. So I think as a group, DPP4 inhibitors, it's now more than 15 years that we have seen that this is the one of the best class of drugs which can be used across the spectrum of diabetes. So it can be used across the spectrum of diabetes. It
Hello.
can be.
Vinay, I cannot start my video.
So today I am going to talk around the, I would say not the new kid on the block, but a special DPP4 inhibitor that is Evogliptin. So it is a selective, potent, and a reversible inhibitor of DPP4. That we'll just see how it differs when it comes to the other molecules. It was first approved in South Korea, you will see in 2015. So it is not a new molecule. It is almost now more than a decade old. And then in 2019 is where around that time we got approval in India as well for treatment of type 2 diabetic patient as an adjuvant to monotherapy. So dosage is 5 milligrams once daily. Let's see how it differs from its fellow colleagues. I think this is going to be the most important slide. So are all DPP4 inhibitors same? So I think we all know that most of them are similar when it comes to the efficacy part, but let's see when it comes to the action, how they differ? So the DPP4 enzyme you will see has S1, S2, S1 dash, S2 dash extension, and a S2 extensive.
Sir, I'm sorry, but your slides are not moving.
Are they moving now?
No.
Are you able to see it now?
We're just seeing your first slide till now.
Now you're able to see the slide?
Yes, so now we are able to see.
Okay. I'll just put it in. Now is it moving? Are you able to see the slides change?
No, sir. We're still on the fourth slide.
Now did it change?
No,
did
sir.
it change?
No, sir.
Okay, no problem. I think I'll just go ahead with this. You're able to see this, right?
You're able to see your mouse move.
Okay. You're able to see the slide also, right?
Yes.
Okay, I think I'll just go with this one then. I will not go into the PowerPoint. So what is so specific about Evogliptin is Evogliptin binds to the S1, S2, and you will see the S2 extensive binding sites. So that is how it is different when it comes to its fellow colleagues. So I will not go into the details of the pharmacokinetics. We all are clinicians here, but you will just see the plasma concentration peaks around 3 to 5.5 hours. The inhibition of DPP4 is rapidly surpassed, so 80% in less than an hour, and the half-life is really very long, so it is around 32.5 to 39.8 hours. So there is more than 80% of the DPP4 inhibition which happens, you will see over the period of 24 hours. I think this is where most of the DPP4 inhibitors differ from each other. The postprandial GLP-1 rise, so that goes as high as from 1.5 to 2.4%. And you will see the PPG levels goes down by 20% to 35%. There are a lot of studies, international studies. There are certain Indian studies also. I'll just rush through it considering the delay in the time. So this was the international study. This is the phase 3 study where Evogliptin monotherapy was used in patients with diabetes. It was a randomized, double-blind, placebo-controlled, well-matched study which had around 160 odd patients. So you will see the results. Evogliptin 5 milligram monotherapy significantly decreased the A1C, as was well tolerated in patients with diabetes inadequately controlled on diet and exercise. This is another study, the bridging study, which was seen to see the efficacy and safety of Evogliptin in type 2 diabetic in a Brazilian population. So again, here it proved that once daily treatment with Evo was very safe and well tolerated. So the adverse events were almost similar. I think the only adverse event, if I have to talk about, is the nasopharyngitis and some amount of viral myalgias, which we have seen with most of the DPP4 inhibitors. This is the evergreen study. So here the objective was, this was a head-on study to see the efficacy and safety of Evo versus linagliptin. So again, I think most of us have very good experience of Lina. So to confirm the influence of Evo on the glycemic variability by measuring the continuous blood glucose levels. So you will see one arm, the patient was started on Evogliptin, another arm, the patient was started on linagliptin, and they were followed up for 24 weeks. You will see the A1C reduction. So there is hardly anything there. If you will see the A1C reduction between both the arms, it is almost similar. Changes from baseline in glycemic variability. So this is a more important parameter. You will see it was much, the MAGE reduction was much better with Evo when you see it with linagliptin. And the standard deviation of glucose again with Evo was much better when you compare it with the linagliptin. In a time where we all know that it is not only important to control sugars, but it is very important to maintain the glycemic variability, because we all have understood that it is the glycemic variability, the higher the glycemic variability, your patient is more prone for developing the other complications. So now we're looking at drugs which will not only help you to reduce sugars, but which will help your patient to have less glycemic variability. And here you will see the changes from baseline and glycemic variability with Evogliptin. So to conclude, when Evo was orally administered for 12 weeks for type 2 diabetic patient, the mean change in A1C you will see versus the Lina was 0.85 and 0.75 in the Lina group. This proves its non-inferiority to the Lina. It is considered a safe and effective anti-diabetic patients for diabetes patients who have uncontrolled. At 24 weeks, Evo also resulted in an improved glycemic variability measured by the CGMS. So I think this is very important factor which makes it a little different from its fellow colleagues. Now, can it be used in patients with comorbidity? So let's see in renal dysfunction. The drug was found safe in all grade of kidney dysfunction. So you can give it in patients with mild to moderate to severe renal dysfunction. So it could be given across the spectrum of diabetic patients with nephropathy. Let's see the pharmacokinetics and safety of Evo in patients with hepatic impairment. Here also, there is no dosage adjustment which is required in patients with mild to moderate hepatic impairment. So it is not only that you can give it in patients with renal, but patients with a mild to moderate degree of hepatic dysfunction as well, you can use this molecule very safely. Does this have any effect on the NAFLD? I think we are moving ahead from the term of NAFLD to MAFLD. So I think now we are in a time where NAFLD will be renamed probably in future as metabolic associated fatty liver disease. So let's see, does this have any effect on the NAFLD? So this trial said that 24-week trial demonstrated that Evo was safe and showed a trend in reducing the liver fat for patients with diabetes and NAFLD. I think most of our diabetic patients we know have an underlying NAFLD. Coming to the cardiovascular risk. So this is a nationwide population cohort study in South Korea to see the cardiovascular risk in patients treated with Evo. So describe the demographic and clinical characteristic of patients with diabetes with glimepiride, DPP4 or SGLT2 inhibitors in South Korean patients. So here you will see the use of Evo either decreased the risk of CVD or had no association with it. So now it definitely proves that it is also cardiovascular safe, at least it is neutral when you compare it with your other class of patients. Let's see the combination therapy. So whether the combination of Evo and metformin, how does it work? So there are a number of studies which were done with it. You will see the addition of Evo added to metformin 1000 milligram improved the glycemic control and was well tolerated in type 2 diabetic patients, and when it was studied in comparison with sitagliptin. So again, in Korean population, of course, this was done. This shows its non-inferiority to the gold standard sitagliptin when it was used as a combination therapy. So now it is one class of drug, I would say one molecule, which has multiple effects, which has multiple studies which are done. Not only one study, but it has multiple studies. The safety of Evogliptin is now very well established. So now let us see what Indian data we have. Especially, I think in a country like India, we've seen that right from the launch of DPP4 inhibitors had a better A1C control in Asians, in Indians, when that was seen, when it was compared to the clinical trials, what was done. So this was a study which was done in India. It is a retrospective observational study on usage of Evo in type 2 diabetic patients, a real world experience presented at the RSSDI National Conference. So I would just go to the conclusion. It said that Evo was found to be effective when added to patients who were uncontrolled on dual or triple therapy. So you will see that it was added to patients who were on two drugs like glimepiride and metformin not getting controlled, then Evo was added. It was added to triple therapy as well. So when it was given as monotherapy, you will see the A1C reduction was around 0.9%. When it is given along with metformin, the A1C reduction came to around 1.4%. Let's see the Indian data, the CGM study. So this is again a retrospective observational study, a real world experience, again the same thing. The results, again, the Evo was found to be effective when added to patients on uncontrolled OHAs. It effectively showed improvement in continuous glucose monitoring and time in range. I think this is the word which we all will hear day in and day out, that is the TIR, where most of the time we want our patients to at least spend more than 70% of their time in a day in the time in range. So most of the patients achieved that TIR when they were started on Evogliptin. This is the ADA study. Again, this was published, this was talked about in the ADA, the efficacy and safety of Evo plus metformin added to insulin therapy in elderly Indian patients with type 2 diabetes. Here you will see that it is very effective and it is very safe in patients when added on insulin therapy as well. And the decrease of A1C is around 1.2%. So one thing again which came out is that it is not only very effective, the TIR is well maintained, and then you will see there was no change in the body weight. So there was no increase in the body weight, and then definitely there was a decrease in the insulin requirement, which was seen at the end of 6 months. This is again a study of effects of Evo as an add-on to type 2 diabetic patients inadequately controlled on metformin and glimepiride. This is a data of 185 patients who met the inclusion criteria, were extracted for analysis from hospital and clinical records. So again here it concludes that Evo is suitable add-on to patients who are uncontrolled on metformin and glimepiride. The chances of hypoglycemia is very less. And then you will see there was not only fasting, but there was postprandial reduction and better A1C control in patients who were started on this therapy. This is a post-marketing surveillance which was done for the fixed dose combination of Evo with metformin. Again, here you will see the baseline A1C reduction, which was very nice, even in the combination therapy. So to summarize, it is a true once a day because of its long half-life. It has established renal, hepatic, and cardiovascular safety without the need of any dosage adjustment. So it can be given very safely across the spectrum of patients. As per the Evergreen study, the 24-week study versus the LENA, we saw that it was non-inferior when it came to the glycemic reduction, and patients had a better time in range when compared to the other. With the 3 head-to-head studies against CETA, Evo again proved to be its non-inferiority with sitagliptin, which is one of the most gold standard drug in the Indian study as well. And the combination therapy with metformin once daily gives you the similar result what you will give it as an individual therapy. So in the end, I would like to tell, in this era of SGLT2 inhibitors, DPP4 inhibitors, it is, I know, very difficult to select which DPP4 inhibitor. So when you have patients with diabetes, with comorbidities where you're worried about, then this drug would be the ideal drug of choice. So thank you.